online. Go ahead.
Okay. Let's check a minute. Yeah. Good day, everyone. We welcome to the Learning Basic Arthroscopy series of lectures. Today, we have a very interesting topic, that is multi-ligament knee injuries. We have very good faculty with us, experienced and renowned faculty. So let me please introduce Mr. Pavan Kumar, and Dr. Srinivas is going to introduce Dr. Sachin Tapasvi and Dr. Rajarshi. Thank you very much for joining us, and thank you very much, sir, Dr. Sachin, sir, and Dr. Rajarshi for joining us, and thank you, Dr. Pavan. So let me please share my screen. So Pavan Kumar Ravi, he has joined us earlier. He is consultant orthopedic surgeon. He completed his master's in orthopedics from the renowned KEM hospital from Mumbai, India. He is presently a consultant orthopedic surgeon at Skin to Bone Super Specialty Clinic. He has completed fellowship in arthroscopy with our own senior faculty today, Dr. Sachin Tapasvi. He has also done his fellowship with Dr. Sugaya, the renowned shoulder and elbow arthroscopy surgeon. He was also the Asia Pacific Arthroplasty Society Traveling Fellow for the year 2017. Welcome, Dr. Pavan. Thank you for joining us today. I hand over to Dr. Srinivas.
Thank you, Sasi. Good evening, everybody, and welcome back. We have three special guests today, as Sasi has introduced Dr. Pavan, Dr. Sachin Tapasvi, and Mr. Rajarshi Bhattacharya are the other two guests. Mr. Bhattacharya will be the moderator. He's a special invitee from Imperial College in London, UK. It's really an honor for me to introduce our guests today, Dr. Tapasvi. I hope I will do justice with this short summary for both our guests today. Dr. Tapasvi currently holds positions and affiliations include he's the consultant and head of orthopedics at Oyster and Pearl Hospital, Pune, and panelist surgeon at multiple hospitals in Pune. And he's the president-elect of Indian Arthroscopy Society from 2019 to 21. His current positions and affiliations include the chief editor in Asian Journal of Arthroscopy and Arthroplasty, an executive member of Asia Pacific Knee Society. In ISACOS, he holds the deputy chair in Knee Sports and Preservation, member of newsletter committee, and member of program committee, member of the publication committee. And for the Asia Pacific Orthopedic Association, he's a chairman of newsletter committee and committee member of sports chapter and committee member of hip chapter. He did his MBBS and MS Ortho from BJMC Pune with both with gold medals, and passed DNB and awarded MNAMS and conferred FRCS, Royal College of Physicians and Surgeons of Glasgow, and AFAOA from Australia. He received specialist arthroscopy training from renowned surgeons both nationally and internationally, from Dr. V.B. Basin, and internationally from Dr. James H., Mr. David Pollock, Mr. Andy Williams, Mr. Andrew Wallace, Mr. James Calder, Dr. Adolph Lombardi, and Dr. Vincent Burke. He had delivered more than 600 invited lectures and talks nationally and internationally, and he's been involved in more than 50 webinars and nearly 100 live surgical demonstrations and more than 70 cadaver courses and workshops. He has more than 50 peer-reviewed journal publications and 5 book chapters, and he served as Vice President of Indian Orthopedic Association 2015 to 2017, and serving as the Indian European Arthroscopy Arthroplasty Foundation President since 2015. And he holds life memberships in major orthopedic associations. He's been successfully conducting the Pune knee course with more than 1,000 delegates attending each year for the last 3 years, and trains 4 fellows annually in a well sought after fellowship recognized by the ISA course. The key areas of his interest, research interests, are in evaluating patient-reported outcomes in various arthroscopy knee procedures, such as meniscus repair and rotatory instability associated with ACL instability. And he has delivered multiple public speeches and programs. We welcome you, Dr. Tapasvi. It is also an honor for me to introduce Mr. Rajarshi Bhattacharya as well. I'm grateful to him for his support as a senior friend and colleague during my stay in the UK. Raj Bhattacharya is a consultant trauma and orthopedic surgeon and clinical director of orthopedics, plastics and major trauma at Imperial College Healthcare, NHS Trust, and Northwest London Major Trauma Centre. He is currently in his second term as president of orthopedics section of the Royal Society of Medicine, London, and was a member of the PLAB 1 committee of the GMC from 2013 to 16, and for PLAB 2 committee from 2014 to 17. He also acts as an advisor to the Parliament and Health Ombudsman of UK. His main interests in orthopedics include all aspects of knee surgery and trauma and fracture surgery. Raj Bhattacharya started off his initial medical career in Scotland, following which he moved to Northeast England to complete basic surgical training. Here he completed master's degree in orthopedics and trained as specialist registrar in trauma orthopedics within the Northern Territory based at Newcastle upon Tyne. Subsequently, he trained as a specialist knee surgeon and undertook 2 prestigious knee fellowships, first in Edinburgh Knee Unit and then at the Southampton Knee Unit. He also trained as trauma specialist with a fellowship at world-renowned Edinburgh Trauma Unit, and was appointed as consultant trauma orthopedic surgeon at Imperial College in London in 2010. He was conferred fellowship of Austrian, Swiss, and German orthopedic associations in 2012. Raj consults on a wide range of emergency and elective orthopedic conditions. His areas of expertise include acute orthopedic injuries and complex trauma, as well as all aspects of knee surgery, including partial and total knee replacements, minimally invasive surgery, and soft tissue and ligament reconstructions of the knee. He specializes in robotics assisted knee replacement and uses 3D customized prints to correct post-traumatic lower limb deformities. He also has active research interests in these areas and published several peer-reviewed journals, including Nature. He has been involved in orthopedic teaching and training, initially at Newcastle and subsequently at the University of Edinburgh, and currently continues at Imperial College in London. Raj completed his MBA as well, with distinction from Imperial College Business School, and currently enjoys a portfolio career acting as a non-executive director in some organizations and sitting on the boards of various startup companies. Welcome, Dr. Sachin, Tapasvi, Pavan, and Raj. It's an honor to have all of you with us today. I request Dr. Pavan to start his talk. Thank you.
Right. Am I enabled with screen share? Can I start screen sharing? Okay. Everyone visible? My
Yes.
PowerPoint?
Yes, visible.
Sorry. Right. I thank Dr. Sachin Tapasvi, sir, my guru, my guide, for whatever I am today, and Dr. Sasi and Dr. Srinivas, thanks for the re-invite to give another talk on this podium. Going through the acute phase management in knee injuries, Dr. Mills and his team has this interesting publications on this particular topic. They have vast experience on this. According to them, the knee dislocation contributes to about 0.2% of all orthopedic injuries. Very commonly missed because of the spontaneous reductions that occur in about 20 to 50% of the knee dislocation cases. 14 to 44% are associated with polytrauma with multiple fractures and injuries. And about 5% of these knee dislocations tend to be bilateral. So if you see the stabilizers of the knee joint, you can classify them as static and dynamic. The static ones are the joint capsule, the collateral ligaments, the MPFL, while the dynamic ones are the muscles around the knee, predominantly the quadriceps, the biceps femoris, the pes anserinus, the gastroc, the tensor fascia lata, and the popliteus. So mechanisms for injuries are predominantly road traffic accidents where the dashboard injuries with the knee in flexion or hyperextension injuries in contact sports. The fall on flexed knees with foot being plantar flexed and anterior bowing of the knee are the common mechanisms by which you can expect to have a multiligament knee injuries or knee dislocations. So when you come to when you're dealing with clinical examinations, your thing is in relocated knee, it's really difficult to identify whether it's just contusions, ligament sprains, or something else. It may totally appear normal in a supine position. Only subtle changes such as ecchymosis, effusion, abrasions with mild recurvatum. So recurvatum is predominantly to be looked for, and painful restricted ROM than a normal expected symptom. If it's too much of painful as compared to the physical appearance, you need to keep in mind spontaneously relocated knee dislocation. In cases of extremity fractures, that makes the situation even more complicated and evaluation becomes further difficult. So examination under anesthesia after fracture fixation is a priority. When there is an obvious clinical deformity, I would definitely not wait for radiographs. I would, especially in scenarios with absent pulses, I would recommend spontaneous reduction in the ER itself, emergency room, and look for dimple sign, that's buttonholing of medial femoral condyle through the medial capsule. It's usually indicative of an irreducible posterolateral dislocation. Vascular assessment is of top priority. Just before and after reduction, make sure that you have examination of your vascular system done properly. Palpate for both dorsalis pedis and posterior tibial pulses and compare them with the uninjured or unaffected side. If pulses are present or normal, does not uh, negate an arterial injury possibility. Collateral circulation may mask completely the popliteal artery occlusion. So you need to be aware that collaterals are very much active. Ankle brachial index has been a predominant indicator for your risk assessment in arterial injuries and knee dislocation. If ankle brachial index is more than 0.9, you can be relaxed. Just do serial monitoring, and it has a almost 100% negative predictive value when the levels when the ankle brachial index is more than 0.9. If ankle brachial index is less than 0.9, that's where you need to perform either a ultrasound guided Doppler or a CT angiography would be ideally recommended. If arterial injury is confirmed, then of course the vascular surgeons would come into picture. If pulses are absent or diminished, that's where you probably need to look into when it's like the gray zone, where you're not sure whether it's due to the swelling or due to something else. So see whether the joint is reduced or not itself first, and then reduce it. And based on that, after reduction, how much the pulses are, whether they're reduced or not, you have a relook. Ischemia time more than 8 hours has a very high amputation rate of almost 86%. If pulses are present and they are back to the normal levels of ankle brachial index, then we just need to observe and consider angiography at a more elective state. Neurological examination is of importance, especially peroneal nerve, where the incidences are found to be almost 14 to 35% or times in a knee dislocation we may have a peroneal nerve injury. So this occurs most commonly with varus traction injury. You obviously examine the extensor hallucis longus or tibialis anterior strength, dorsal web space sensations, and this has about a 25% chance of returning to functional normalcy. So you would consider it to be a poor prognosis. Tibial nerve injury was always rare. I went through literature, but I couldn't really exactly notify the numbers or the incidence of percentage-wise, how much percentage incidence is there, but it's reported to be rare. That's what is written everywhere. You obviously look for flexor hallucis and gastrosoleus strength, lateral border, and plantar surface foot sensations for your tibial nerve, but incidence somehow I could not find with percentage wise. Anatomic classification of knee dislocation is my most preferred. There are a lot of directional and other classifications, but I think this is the most useful one, which describes KD1 as single ligament is in, one of the cruciates is intact. Bicruciate rupture with both collaterals intact is rare. So bicruciate and medial collateral is 3M. Lateral collateral injury with bicruciate is 3L. All ligaments is 4, and when you have an added component of arterial or nerve, then they categorized as C and N. So, imaging modalities, of course, you have plain X-rays, Doppler, venous and arterial both. CT scan to rule out any small fractures, missed out fractures are better visualized in CT scans. Then CT angiogram to rule out vascular injuries, and of course MRI once you're uh, clear that it's purely soft tissue injuries. So, what's your goal of treatment when you have a dislocated knee? You have to sort out your priorities. In that, I would say achieve a painless, stable knee with a good range of motion and return to pre-injury level as far as possible. So that would be your goals of treatment. So in close reduction maneuvers, so you can attempt for an anterior dislocated knee, traction and elevation of distal femur. For posterior dislocation, traction and extension of proximal tibia. Medial or lateral, based on that, traction and translation. And for rotational, obviously traction and derotation. But avoid forces applied against popliteal fossa for your reduction maneuvers. When you have such irreducible knee dislocations, I would definitely not risk skin necrosis because of by making multiple attempts. I would straightforward go for an open reduction. So after you have done your open reductions and or closed reductions, knee immobilizers offer stability in very few cases. You need these are predominantly for the stable ones and say like KD1, 2. Skincare is needed for open injuries. You need all your open injury protocol for management of your open injuries. Fasciotomy for compartment syndrome, which may definitely set in high velocity injuries. You need to be watchful about compartment syndrome, and definitely no to casting. I'm strictly against cylinder cast or above knee cast for your knee dislocation cases. External fixation is ideally recommended for unstable or subluxating cases in braces. In obese patients, it's highly recommended that you put an X-fix. In polytrauma, of course, to speed up your stabilization of a polytraumatized patient. And in cases of vascular repair, to protect the vascular stump that's been repaired, it's better that you have an external fixator. Most authors have recommended repair of tone structures. Non-operative treatments have often yielded in poor results because period of immobilization, if it's short, you have good movement but residual laxity. If it's longer, you have improved stability but limited motion because of atrophy.
Dr. Pavan.
Sorry, my network was bad. Am I
Yeah,
still?
you're audible. You can share your screen again.
Okay, so so recent clinical studies suggest better reportings with early operative treatment, repair the ligaments as early as possible, wherever repair is possible. And there, the problem is you can't have a prospective, controlled, or randomized trials for such injuries. So you really can't compare. So it's the word of the surgeon that you have to believe. It's a matter of experience that counts, where the surgeon is putting up rather than putting a prospective controlled randomized trials. So a loose mobile knee is better than a stable stiff knee is what is to be believed. So to summarize, anatomic classification is a more dependable classification system for knee dislocation. Use of angiography has to be emphasized. Ankle brachial index is more important than anything else in knee dislocation scenarios. And individualized surgical treatment is of importance. Associated injuries need to be addressed. Definitely fracture fixations, vascular injuries, nerve explorations take a priority definitely. And limited surgery like the corners, I always prefer to have more rotatory stable scenarios and collaterals being repaired as primary surgeries for me. In polytrauma and neurovascular, of course, you would have all these associated injuries being at. Thank you for your patient listening. I would end my. I'm done with my talk.
Yeah, thank you very much, Dr. Pavan. That was very informative. Thank you very much. I think we will be having all the questions later. I kindly welcome Dr. Sachin Tapasvi to carry on with your presentation.
Yeah, thank you so much for the opportunity, and it's a great privilege to be speaking in front of all of you. This is a great topic. I think all of us really need to be aware of these multi-ligament knee injuries. And what's important is these two great people here right in front of on my screen here, Dr. Saseendar and Dr. Srinivas, who are so committed to the cause of education and sharing knowledge, which is indeed, I think, one of the greatest attributes for any human being nowadays, to be completely selfless and to be able to share everything that we know. And I salute both of you for your great venture. I think it's also very important for me to acknowledge a very good friend, Pavan, whom you just heard speak a while ago. Pavan's been a fantastic sort of fellow with me, but I think he's gone miles ahead, and probably he's there right where he should be, and he's ready to impart all the knowledge, all the teachings to everyone. And congratulations, Pavan, and wishing you all the very best in years to come. So with a thank you note to these couple of these two stalwarts and my good friend Pavan, I think it's important that I re-emphasize that all of us who want to learn and want to share should join this particular group. So it's important that we should join this group. It's a private group, but you can't have a private group which is 8,500 members strong. This is easily going to reach and cross the 10K mark very soon. And I think this is going to be a very important force guiding all of us, especially in education. What's also important is that we need to share all our knowledge. And I think we at the Asian Journal of Arthroscopy, again, thanks to Dr. Ashok Sham and his team at IORG, have been sustainably, continuing with this journal. And the current edition is actually dedicated to multiligament knee injury. And I'm going to encourage all of you to visit asianarthroscopy.com and browse through this current issue, which has got 10 fantastic articles which have been written up on these very important aspects of multiligament knee dislocation. And I really welcome all of you out there to contribute to this fantastic journal, because I think we need to share and we need to educate ourselves. Another important activity is our Pune knee course, which unfortunately the COVID has forced us to change it to dates for next year, which is going to be from the 22nd to the 24th of April. The trauma, the whole focus of the meeting will remain the same. And I'm going to welcome all of you when we have better times and when we can actually shake hands in person and enjoy a nice cup of coffee and share good camaraderie. So the first thing to understand is multiligament knee dislocation is not a knee dislocation. So when you have a multiligament knee injury, it is not a knee dislocation, because per se, a knee dislocation definition implies that you should have a bicruciate tear with or without one collateral injury. You can have a multiligament knee injury without a bicruciate, and this is the crux that we all need to understand. A multiligament knee injury can be as a result of high energy trauma or low energy trauma. And interestingly, low energy trauma accounts for almost a third of all cases, which is something that we all need to really remember and understand and be very vigilant about. What's also important is that when you have morbid obesity, you can have ultra low velocity injury. And with these ultra low velocity falls, especially in the morbidly obese, you can actually miss out a multiligament knee injury or a knee dislocation, because the whole leg is so huge that you just can't notice a deformity that's happening inside. What's really very important is that these injuries have a very high incidence of neurovascular complications, which is why you need to really look out for them and look at them very carefully. So Bob Schenk gave us this fantastic classification for multiligament knee injuries, wherein Dr. Pavan has alluded to the same, where you have a KD1, which is either an ACL or a PCL with either an MCL, PLC, or both. That means in a KD1, you have one cruciate plus a collateral. You have a KD2 in which both of the cruciates are injured. You have a KD3 in which you have a ACL, PCL, plus either the medial or the lateral collateral. You have a KD4, which is all four ligaments, and you have a KD5 when you have a periarticular fracture. Interestingly enough, this classification was given to us by Bob Schenk, and Bob Schenk will be with us in Pune for the Pune knee course. And I think it will be a great time to catch up with the person who actually gave us this Schenk classification. And he will be actually chatting with us one-on-one. And he's a great guy, I promise you, a fantastic person to know with. So I'm going to start off with some examples. And this is a 43-year-old male who is into construction. He had a motor vehicle accident, and he's got a KD4. He's got ACL, PCL, MCL, PLC, neurovascular intact. He comes to me with this kind of X-ray and this kind of an MRI picture. So what I want to actually show you here is that when you see these MRI pictures, what can you see here? You can see that on these MRI pictures, we have the following. We can see that there is essentially, I don't know why this is coming. Can someone just take off this annotate button, which I can see here? I'm not so sure why I'm seeing that. Okay, so anyways, so what you can see here is that starting in the top left corner, there's an ACL rupture, but it's a low velocity ACL rupture. Coming across from the top row, the next picture to your right is a posterolateral coronal injury. The next one, coronal sections, are showing you the presence of medial and lateral sided injury, and surprisingly, the bone bruise is quite less. Okay, so you see this chap's MRI scan. He's now about 5 days, 6 days post injury. Well, when you examine him, he's got laxity of all his 4 ligaments, but he doesn't have a huge bone marrow edema pattern. You go ahead. Ouch. What's happening here now? Yeah. You go ahead and you examine him, and that's what you see. Well, what do you see here? You see that he's got...
I'm sorry, Dr. Sachin, we lost your presentation.
Yeah, 1 second. I'm just going to redo it once again. I don't know what happened. That annotate button came in. Yeah. Just give me 1 moment, please. I'll just
no problem.
get to the bottom of this very quickly. Where am I now? I can't see myself. Yeah, okay, I got it now. Very sorry for that. Extremely sorry. Where was I? Okay, yeah, there I am. Is it okay now?
Yes, sir.
Yeah, so that's what I see when I examine him clinically. He doesn't have too much of laxity, though he's got like a KD4. And when I see him walk, I braced him. This is what I see. This is how he is. 2 weeks after just a simple bracing. Of course, the brace that we've given him is a PCL brace. And this is his stability and his laxity at the end of 3 weeks. So what is the lesson that I learned here? That all KD4s do not require surgery. In someone who's probably low demand, who doesn't have too much laxity, his MR scans do not show too much of bone bruises, you can actually treat them conservatively. So I think this concept that we have fixed is that whenever there's a MLKI, put him into surgery, start, get your 20 number blade, get your scope out, start harvesting grafts and start fixing him is not correct. Choose discretion, look at the MR scan pattern, check the laxity pattern when you examine them clinically, put them in the appropriate brace and splint. So a hinge knee brace will never work if there's a PCL dominant component, because in spite of a hinge knee brace, the knee will continue to sag down. So these people will require a special PCL brace which holds the tibia in the reduced position and put them in the proper rehab. The next case we have is a 32-year-old policeman. Again, he's got a 1-week-old motor vehicle accident, and he's got a grade 2 MCL, he's got a grade 3 PCL, and a grade 3 ACL. So this is a KD3M, which we have here. His neurovascular is intact. And of course, when I discussed with him, I did discuss the following plan. I told him that I can, primarily repair your MCL, do the collaterals first, and then do a delayed ACL and PCL. Well, that's what we end up doing most of the times. Or I said, I could also conserve your MCL. We know that MCLs do heal well non-surgically. And then at a delayed time, do your ACL and your PCL reconstruction, evaluate your MCL and decide if I have to do anything to the MCL then. That was also a good option. Or the third plan was to do a primary ACL, PCL, MCL repair or reconstruction. So now you need to understand 2 things when you're looking at this particular plan as to whether these collaterals and these cruciates are repairable or not. And that's when you study the MR scan, and he had avulsions of both the ACL and the PCL from their femoral origin. He had an avulsion of the MCL, and he was a reliable chap. He was a policeman, and this is one person whom you can think of doing a primary open repair surgery. So at the end of 7 days following his injury, I went in through a medial approach. Nature, by doing an MCL tear, has already created an arthrotomy for you. You just have to extend that arthrotomy. And once you've extended that arthrotomy, what you need to do is put a couple of strong sutures in the stumps of your ACL and your PCL. and reattach them back to their bony, to their origins by the help of strong suture anchors. And at the end of the procedure, you want to go ahead and repair the medial side. You can see the repair there, and you've augmented it with the help of some tape as well. So this is an example in which you can do a primary ACL, PCL, MCL repair without sacrificing any of the host tissue, thereby preserving all his autograft sources for any sort of inevitability. If this surgical procedure was due to fail, then he could have easily gone back and used his own natural graft and reconstructed. Post-operatively, you need to really brace them properly. And because this was again a PCL dominant injury, I braced him starts squatting and a step-up program, and at the end of 3 months, he then goes to functional exercises and isotonic exercises as well. So that's how this post-op protocol goes. But what's important is that in these patients, you need to have good progression of therapy, and at any time if you find that you're not able to reach the 3, 6, 12, 18-week landmarks, then you need to change and alter your program, which is what I had to do, because at the end of 8 weeks, he was quite stiff. And then in these patients, you don't want to do an you don't want to do a manipulation under anesthesia. You want to do a proper arthroscopic release because you don't want to be ripping out abnormal tissue. And that's what I did for him. I went ahead, did an arthroscopic adhesiolysis, released a bit of scar tissue in his suprapatellar pouch, was able to achieve full range of motion, and then he could complete the rest of the program quite efficiently without any problems. So primary repair is a good option. You have to select the ideal candidate. He has to be very compliant. It has a lot of advantages because it avoids secondary surgery. You don't compromise any graft source. And of course, you have the best biology, the best ACL graft, the best PCL graft, because you're just suturing the patient's own stumps back. And it's important that you select a patient in whom you have a avulsions of the cruciates, and that's the one that you need to reconstruct. Next example is this 32-year-old lady. She comes a day after her injury. Again, she's got a KD3M. She's got a grade 3 MCL with opening at full extension, as well as 30 degrees of flexion. So she's got a grade 3 ACL and a grade 3 PCL, and this represents a nasty injury. Now, what does her MRI scan show? It shows that there's significant bruising. She's got a lot of bruising on the lateral tibia and the femur as well, which implies that it's a high energy. And what we can also see here is that she's got an avulsion rim fracture fragment as well, which means that this is not the best person to do a single stage surgery, because this is going to be an angry knee, so as to say, and any form of sort of acute surgery for all the three torn ligaments will lead to a stiff joint with arthropfibrosis and maybe late arthritis. So in these, I will adopt a two-stage procedure in which in stage 1, you want to go ahead and fix the collaterals. So go ahead, take a generous medial incision. I've seen people struggling, repairing collaterals by making small incisions. This is not the place for MI surgery. You need to do a good dissection, go layer-wise. You start with layer 3. So you first repair the meniscotibial ligament with the help of suture anchors. Once you've repaired layer 3, then you go to layer 2. Again, repair that, and then you will augment your MCL repair with the help of soft tissue graft. And again, she goes into a PTS brace in extension for 3 weeks, no range of motion. 3 weeks after the repair, she again goes back to a PCL brace, start with passive range, and then she moves on to progressive strengthening. And once she's achieved 80% of strength and 80% of movement compared to the contralateral side, then she goes in for surgery. And my choice is to use ipsilateral graft. I usually don't like to touch the opposite knee. And what I've done for her is an ipsilateral BTB and a CQT. So that's a single bundle PCL reconstruction in which I've chosen a BTB graft for her. And that's negotiating the killer term for her PCL, fixation there with an interference screw. We've preserved her PM bundle and done a predominantly AL bundle PCL reconstruction. Of course, whenever I'm dealing with knee dislocations, I usually tend to prefer a single bundle PCL reconstruction. And on the ACL side, I've used a quad tendon graft, which is a split quad tendon, thereby preserving her extensor mechanism. And that's the PCL tibial screw coming up till the mouth of the aperture. And you need to see it come right into the aperture on the posterior aspect. And then that's the ACL graft that is getting pulled through, getting in right there. And that's how you would do a delayed ACL PCL reconstruction for this particular patient. So that's what we ended up doing, a delayed ACL PCL reconstruction, again goes back on rehab program and comes properly. So I think it's important that we need to fix these multi-ligament knee injuries because of a very high chance of arthrofibrosis as well as arthritis. And it's important that we treat them aggressively. We treat them with an anatomic approach. And of course, what I've tried to demonstrate here is the continuum of treatment, right from non-operative to primary repair to stage reconstruction. And you need to be really aware of which one you want to use, and you have to pick your winners for the same. So if time permits, I'll move on to the next part, which is looking at chronic and neglected multiligaments. So Dr. Saseendar, are you okay for me to continue, or you want to take questions now?
Yes, sir. Please, we want to listen more.
Perfect. So I move on to the next part of these MLKIs, which is chronic and neglected. And the first rule here is bone always wins. And I'm going to come to that in a bit of detail, but just remember this: when you're dealing with a chronic or a neglected, bone always wins. And that's what you need to do first. Bone always wins in three situations. First is when you have a KD5 in which the primary treatment has not been done properly. So you have a malunited periarticular fracture. Usually these will be either Hoffa's fractures for the femur, or they are posterior tibial shear fractures which have not been fixed properly, or tibial condylar fractures, or as a result of the ligamentous laxity, you have malalignment both in the coronal and in the sagittal plane. So you first look at the alignment. If the alignment is neutral, then you go ahead and do a collateral and a cruciate reconstruction, which is what we discussed in the first part. But if the alignment is abnormal, you want to look at both the sagittal and the coronal plane alignment, and then you have to realign them. And that's the fourth part of your multi-ligament knee injury treatment protocol. We discussed the first three, which was leave alone, repair, and reconstruct. And now we come to the fourth way of treating them, which is realign. And that's again very important. And once you've realigned them, then you go back to reconstruction. So that's the algorithm that you need to follow. So before we decide to realign, we need to know what to align and how much to align. And for this, you need to have good X-rays. This might sound like a boring radiology talk, but a proper done scanogram film is going to be the key to success. And this is the same person standing in front of a scanogram X-ray plate in my clinic. We've taken 3 X-rays, one with the feet rotated externally, with the feet neutral, and with the feet in internal rotation. Look what happens to the position of the patella. The patella is aligned and facing front when the feet are rotated internally, and that is what is going to give you the best film. The next X-ray that you need to do is what is called as a lateral monopedal stance film, in which you need to have a complete overlapping film of both the femur and the tibia, and it's on this that you calculate the tibial slope and you also see if there is any subluxation of the tibiofemoral joint. How do you calculate the posterior tibial slope? You draw your mid-sagittal line, you draw a perpendicular to it, you will draw a line along the tibial condyle, which is usually the medial side, and this is how you calculate the tibial slope. You can also use the posterior tibial shaft line if you want, if you find that you're running short of space on your X-ray films. Why does it matter? Because when you increase the slope, the knee becomes more stable to posterior subluxation. And that's, I think, a very important piece of information that we have. So when you have a PCL deficient knee, the tibia will sublux posteriorly. And in these cases, when you have posterior subluxation, if you increase the slope, the femur will get reduced underneath the tibia. So that's how you do a flexion osteotomy, increase the slope and make the knee more stable. And on the other hand, when you have an ACL deficient knee, then the tibia has subluxed anteriorly. And here we do exactly the opposite. We increase the slope. So here's a patient with a multiple failed ACL. What you can see that the tibia has subluxed anteriorly, and with every 10-degree increase in slope, you will have anterior tibial translation by almost about 6 millimeters, which I feel is a huge thing to have. So when you have an ACL deficient dominant knee, then the tibia will sublux anteriorly, and then you do an extension osteotomy in which you decrease the slope and thereby reduce the tibia underneath the femur again, which helps you to achieve the same effect. So I think these are two important concepts of the sagittal plane that we all should be aware of. And here we can see three different examples. So what are we going to see now? When we look at such scenarios, we first see if the joint is stiff. If the joint is supple and mobile, what you want to see is that is there fixed posterior subluxation? What do we mean by that? When you look at the lateral film, you can see that the tibia is subluxed posteriorly. Try and reduce it. If it can be reduced to neutral, then that means you have a supple joint, and then you can then decide what you want to do. But if you have a fixed posterior subluxation, which clinically you cannot manually reduce to neutral, then you need to look at all of these various things. But when the tibia is fixed posteriorly, then you need to first change your modality of treatment. You need to first correct the subluxation, stabilize the knee, achieve range of motion, and then go back to your alignment surgery. So that's, I think, a very important protocol or an important algorithm. You see if the joint is stiff, if the joint is supple, see if the tibia is fixed posteriorly. If it is fixed posteriorly, then you have to correct the subluxation by releasing the posterior capsule, stabilize the knee temporarily with an X-fix in that position, get rid of the X-fix, achieve range of motion, and then go to your alignment and your ligament reconstructions. On the other hand, if you have a stiff joint, then you first have to do an arthroscopic or an open adhesiolysis, then check for the subluxation, and then again go through the same algorithm principle. And this is what I'll discuss in the next couple of examples. So what we have here is a lady who's got a neglected ACL, PCL, PLC. You can see that she's got a triple varus deformity now. She has a large thrust, and she's got a gross whopping varus when she has a single leg standing X-ray. And going back to the principles, what do we need to do? We need to do a coronal and a sagittal plane alignment and a simultaneous reconstructive surgery. And this is what we've done. We've done a medial opening wedge osteotomy. That's correct. And we've increased the slope because there's a PCL dominant deformity. And at the same time, we've gone ahead and done a PCL reconstruction along with a posterolateral corner reconstruction as well. So that's your first example. Second example, a KD5 in which there was a fracture of the lateral tibial plateau. This was fixed somewhere else, I think in some different state with the help of these two KYs. These were subsequently removed. And this chap, when he presented to me, had a valgus deformity with a splayed lateral tibial condyle with a supple posterior subluxation of his tibia. And that was where he was not happy. These were his images. You can see that there is a bony deformity, and we went in, we scoped him. You can see all the cartilage fragments which were sitting right there. All that you need to do is to go ahead and debride, release. He's 34 years old. Yes, the patella looks bad, but he's not the kind of person whom you want to give a knee replacement. He works with border security force, and of course, he needs to be really active, which is why you want to try and salvage his knee. He's got a deficient MCL. You can see that there's a huge drive-through sign sitting right there. And cartilage doesn't look too bad. He's got grade 2 chondral changes there. He's got, a completely deficient ACL and a PCL, nothing sitting right there. And on the lateral side, the tibial plateau fracture has not been fixed properly. And what you see is chondral changes on the lateral side sitting right there. So what would you do for such kind of a patient? Again, because the deformity is correctable, he doesn't have a fixed posterior subluxation. He's got coronal plane and sagittal plane malalignment. What have we done? We've gone ahead, we've done a single stage distal femoral osteotomy, open wedge on the lateral side, bone grafted it primarily, restored his alignment to neutral. We've done a PCL reconstruction using a 3-strand peroneus longus graft. We've debrided the lateral side of his tibial condyle, and I've also done a primary MCL reconstruction using ipsilateral hamstrings, and that's how I've given him stability. He awaits an ACL reconstruction now, and that will finish his surgical procedure, and he's gone back to serving in the border security force, but at a slightly lower level, which is what is expected. I come now to the third example, a KD5NV, again missed at the time of initial presentation. This was treated with the help of with non-surgically. The lady later required a fasciotomy to save his leg. This was the knee as it was left in a subluxed position. I don't know for what reason. And then in this particular scenario, when I saw him, this is a fixed posterior subluxation. It's a stiff knee. So the first step is to go ahead by a posterior approach, release all the scar tissue, reduce the tibia underneath the femur, bone always wins, fix and realign his posterior tibial shear fracture with the help of open reduction internal fixation. And now you need to maintain this, and I've chosen a static fixator to keep this in place for about 3 to 4 weeks till everything heals down. So these are what are called as flaccid neglected multiligament knee dislocations, where you have flexion loss with axial, sagittal, and or coronal instability after dislocation. And these need to be treated in this form of picture. So step 1, as I said, is that you first will reduce the tibia underneath the femur. So you can either do an arthroscopic release because they're stiff, as I'm showing in this particular demonstration here, or if you're doing open surgery for any bony fixation, you can do an open release. What is important is that you need to release both the medial and the lateral gutters. So this is looking at the knee from a high central portal, and through a high central portal, you want to ensure, that's what you see is the patella. You want to do a 360-degree patellar release. So that's releasing the undersurface of the rectus. And once you've done that, then you go to the back of the knee. You first make your posterior medial portal, start releasing all the scar tissue in the posterior aspect of the tibia till you start seeing the tendon of the gastrocnemius. Then you resect the posterior septum which is there behind the ACL and the PCL, you'll start seeing fibers of the lateral gastroc and the popliteus, and then you move on your dissection to the lateral side, and this is the only way you can release the capsule arthroscopically on the posterior side. Once we release it, we can either span it with the help of static fixators like I showed, or if you have someone who can afford it, then the compass hinge is probably the best thing to use. A compass hinge will allow you to flex the knee, and this compass has its hinge aligned at the junction of the medial and the lateral epicondyles. Once you have this, you can use the compass hinge in the static mode. You can use it in the passive mode, and when you actually turn the knob, the compass will actually start flexing. So the patient can also do passive flexion with the help of this compass hinge, or you can just keep it unlocked and then the patient can do free range of motion as well. This is quite important, quite a handy piece of equipment, but I think the expense sort of is a bit limiting in certain patient groups, which is why we can't use it that too often. And then, as I said, we go to the third stage where you go ahead and finish off your surgical reconstruction by doing your cruciates and your collaterals. So to conclude, when you're dealing with chronic and neglected multiligaments, you have to respect alignment because bone always wins, which is very important. You have to look at different graft choices. Allografts are really great in these scenarios. And if you have just 2 Achilles tendon, you can do ACL, PCL, and PLC and MCL with ease with just 2 Achilles tendon allografts. Of course, the availability is the limitation there. You have to look at different tensioning patterns as to when you will tension each ligament, which is a completely different talk in itself. And lastly, most often than not, these are going to be stage injuries. So thank you very much once again for allowing me to be a part of this fantastic forum, which looks at education. And thank you, Dr. Saseendar, and thank you, Dr. Srinivas, for giving me this platform. Thanks, Ashok and Neeraj from Ortho TV to help propagate knowledge. And thanks, Dr. Rajarshi, to join in through your busy practice and actually endure us in India going through these painful talks, so as to say. Thanks very much once again.
Thank you very much, Dr. Sachin. That was a very, very complex topic that you put forward in a relatively easy conceptual way, and your case series is a very, very complex series that it's very, very difficult to manage. Thank you very much for sharing your experience so far. I kindly request Dr. Rajarshi to take over the session and ask a few questions and share your knowledge also.
Thank you. Firstly, thank you very much to both Dr. Saseendar and Sri, who I know for a long time. And I'd like to thank Dr. Tapasvi for reminding me what Sri looked like with his hair when he was in Imperial with us at the uni unit. It's clearly education has taken a toll on his hair. You can see that. I would like to thank Dr. Pavan firstly for giving a very good sort of basic talk on knee multiligaments and refreshing our memories. I've got a couple of questions that I'll come back to you in a minute, and especially Dr. Tapasvi, your presentation was wonderful. I think you have some fantastic pictures, animation, and actually the compass hinge, I've not seen that before in the UK, so that's actually very handy tools. I've learned a lot from both your talks actually today, so thank you for that. And if I may just start with a couple of questions to Dr. Pavan. You mentioned when you have a ankle brachial index of leg greater than 0.9, one can relax and CT angio is not required. Is that right? Did you feel that you could do away without CT angio and just look for observation?
I would wait for about other symptoms to set in, sir, because there are instances where you've been trying to be very aggressive with CT angios, and some unnecessary vascular procedures have been done is being reported in studies. So they say use your CT angiograms with some discretion. So ankle brachial index more than 0.9 has almost 100% negative predictive value. So that's what most studies are saying. So I would watch him regularly. Probably I won't leave it to a resident or a registrar for looking at it. I would be assessing it as far as possible and then taking a call. I'm not denying that I would sleep peacefully, but my threshold for CT angio would basically depend on frequent monitoring and assessments.
Thank you. I think, I mean, one of the things obviously with multi-ligament injuries is, they go through a spectrum, and on one spectrum you got the major polytraumas that come in with the knee pretty badly done, and the other spectrum is the obese, ladies with a very low volume injury, as Dr. Tapasvi mentioned. I suppose my practice is slightly skewed because I work in a major trauma center, so we tend to see a lot more of the polytrauma that comes in, and I generally tend to have a CT angio pretty much for every patient. And one of the other reasons I am slightly worried about the ABP, ankle brachial index, is if you're going to end up doing major surgery on these patients and you're going to have tourniquet for a long period of time, I'd like to know if there is any intimal damage to the vessels, and that does actually affect whether I use a tourniquet, how long I use a tourniquet or not. So generally, I would sleep less peacefully if I did not have a CT angio, I think, on my patients. I don't know what Dr. Tapasvi's thoughts are on that.
Yeah, I think, I'd agree with you because you're anyways going to do an MR scan on them. I mean, let's leave aside polytrauma. If there's polytrauma and, your other vitals need to be taken care of, that's a different issue. But most often than not, once they're pretty settled, you would take them to the MR suite for having an MR scan done. And I usually prefer to have an MR angiogram done on them, which is, again, a pretty easy thing to do. They're already there in the MR scan. And, I would say that I completely agree with you. I like to actually image the vascular tree. And I would, if in case there's a KD5, looking at bony anatomy there for the fracture that's associated, then of course, then a CT angiogram would fall in place pretty quickly. So I'd agree with you. The other problem with what I would face is that who's going to do an ABI in the middle of the night to just check what's happening there? And whom do you trust for that? That means you'll have to wake up in the middle of the night and go and do it yourself because you can't trust anyone else. You can't trust the nurse to do an ABI. That's for sure.
Yeah, and I don't sleep very well anyway, so I don't think I would in that case.
Yeah.
Thank you for that. That's quite useful. And then another point for Dr. Pavan, you mentioned, and this is more of a sort of my own thoughts. You mentioned that one of the goals of the surgery is to return patients to their pre-injury level, and I would iterate that this for me is a life-changing event, and I would never ever promise them that I'll try and get them back to pre-injury level because I can't. Doesn't matter what state they're in, even if they're in the best of physical ability and rehab, or the slightly elderly obese ladies. I don't think I can ever get them back to pre-injury level, and I make that sort of evident to them right at the beginning that this is not something I can bring you back to normal again. So I think it sets the patient expectations because I think we struggle with these injuries, however versatile you are.
Even for my single ligaments, even for my routine ACLs, I tell my patients that your 92 to 95% activities level is the best that you can achieve because you're not, even with the routine anterior cruciate ligaments, you are functioning at something like one performance level lower than routine. So this is modest, of course. This is a theoretical discussion, I would say.
Sure.
Voice breaking up. My internet connection seems to be slow.
That's okay. Thank you very much for that. And if I can just turn to Dr. Tapasvi and then just ask a few questions on my thoughts. You mentioned about the chronic multi-ligament injuries. Do you do any, again, if you're expecting to do sort of big surgery on them, do you do any imaging for the vascular tree in those situations?
So I think those in whom there's no posterior subluxation, I'm not too concerned. I would do vascular imaging if there's a fixed posterior subluxation. I plan to do an arthroscopic release. Then I need to know, I need to be really aware where the artery is going to be, but many times there could be, altered anatomy. And of course, when you're doing an arthroscopic release, you don't want to be releasing the artery, which is going to be a big disaster. Second, if they've had surgery done previously, there are scars, posterior medial or posterolateral. You don't know what's happened to them. If they've had a vascular repair, you don't know where everything is. And there I would insist on having a CT angio. And I would actually call a vascular surgeon or a plastic surgeon colleague to be there at the time of surgery. Because in those cases, if they've had previous vascular surgery done, or if they've had, say, posterior medial tibial buttress plating done, then I usually have them to completely do a large ultra-wide exposure there, isolate the artery and the vein and the nerve properly, and then I would do an open posterior capsulotomy, and then I would do a posterior release. Then I really won't do an arthroscopic procedure there because you don't know what is stuck where, and and then that can be a big disaster there. So I take your point for sure. Yeah.
So, I mean, one of the interesting things about this is, we talk of evidence-based medicine and all of that, and I did my master's in evidence, but I think this is one case where evidence kind of becomes a bit difficult to collect, and we are going entirely by our own personal experiences, which makes it very difficult to find the right answer. In general, if you're doing sort of a knee which is, say, semi-acute, where you've got type 4, what is your preferred sequence? Do you tend to do all of them together, or what is your preferred sequence? If you've gone through the process of trying to see if some of the ligaments heal and none of them do heal, do you tend to try and consent the patient for doing all of them together, or do you stage them, and what is your sequence of going through those?
And how far would you say was he from the injury?
Say 3 months.
3 months?
Yeah.
3 months, then I would go do all of them at the same setting completely. I don't want to do a couple of them now and then bring them back another, because the time that is spent between these two surgeries is quite large. And I think what's really important is that once you stabilize the complete knee as a complete envelope, the central pillar as well as the peripheral envelope, then only once you rehab them, they can get back the best biomechanics. Leaving by hand a knee which is biomechanically unstable in one plane and trying to rehab them is really difficult, because they can't get their range back, they can't get their complete muscle firing back. And if at all, this is another question that you get asked quite frequently, is that patient has got an ACL and a PCL, he's got a bicruciate ligament injury, which one should I reconstruct first? Can I do the ACL now and then come back for the PCL? I think in olden times we used to have our seniors tell us that first do the PCL and then you can come back for the ACL. I don't think that holds true at all, because you have to have a good central pillar. You have to have your knee completely centered. We know very well what will happen if there is posterior subluxation or anterior subluxation. In the sagittal plane also, what's going to happen if you don't have your collateral sitting there. So I think for me, I'd want to do all the ligaments in the same stage and try and get him back through one rehab, one surgery, and give the best to him for sure.
Thank you. I think I agree with you, and I've had people come and ask me questions in terms of when you're doing multiligaments, what happens if you can't do all of them together, what do you stage? And my answer usually to them is find somebody who can. Because I agree with you, this sort of stage procedure, especially if you're doing it in a controlled way, it doesn't make sense. Certainly in the acute setting, sometimes, and this depends very much on the other associated injuries with the patient, we tend to stabilize it during the extra articular bits, or maybe the postlateral corner, because that's, I think, is quite a key one, and then let them actually recover from the rest of the injuries. But if you're planning them, I do feel that doing them all together is much better. Before I sort of hog the entire session, Srinivas and Dr. Saseendar, do you have any questions from the audience that you would like to ask?
From the audience, I have a few questions. Yeah, Sasi, go on, please.
Yeah. Thank you very much. This is a question for Dr. Pavan and also for Dr. Sachin. Dr. Pavan, is there any situation when the compartments are not actually swollen up, but based on the MRI, you proceed with a prophylactic fasciotomy, or especially in knee dislocation, you want to close reduce and then go ahead with a prophylactic fasciotomy? Or you want to make a reduction and wait and watch? Is there any situation when you will decide on a prophylactic fasciotomy?
I'm not with prophylactic fasciotomy. I've not yet done it, and it doesn't fit my mentality, I guess.
Okay, Dr. Sachin, is there any complex situation when this might be needed?
I think when you have a closed injury with a huge swelling, you have your vascular imaging does show you that there is critical narrowing, but you have preserved vascularity. You feel that this is the time that the muscles are not going to do really well. I think the easiest thing to do is just to do a fasciotomy and save the compartment. Again, if you're doing a concomitant vascular procedure, it's always safe to do a fasciotomy at the same time when you're doing your vascular procedure, and it saves a lot of embarrassment at 48, 72 hours, when you see that some muscle tissue is just dying off and a simple fasciotomy could have saved the day, you can always go back at the end of 7 days, delayed closure or skin grafting, and they don't mind. But they will definitely mind if they lose a bunch of muscle and they lose a nerve. They're not going to be happy at all.
Yeah, I would second that as well. I think if you're having a vascular procedure, for me, fasciotomy is a combined procedure with any vascular repair.
And Dr. Sachin and Dr. Rajarshi, so all these patients will land up in an external fixator, do they? Especially if there is a large subluxation or instability, do all these patients need an external fixator?
I'll let Dr. Tapasvi answer first, and I'll give my thoughts.
So yeah, thanks for that. So I think what you need to see is that how stable is the knee, correct? And you have to keep the knee in full extension. Don't keep it in 30 degrees of flexion. When you keep the knee in 30 degrees of flexion, the collaterals are lax and then the knee will sublux. Keep the knee fully extended. If the knee is completely stable in full extension, it is not gapping medially or laterally, it is not subluxing posteriorly, then there's no need of an X-fix. If the knee is unstable at full extension, or you're not able to maintain the full extension position for whatever reason, or you've done a concomitant vascular repair, then an X-fix is mandatory. So that's when I would bring out a static X-fix. Over to you, Dr. Raj.
So I agree with most of that. I think for me, an EUA is quite essential if I'm getting these patients in. And if in the EUA I'm not happy that this patient will be stable in a PCL brace, I have a very low threshold of putting them acutely into an external fixator for a few weeks. It helps to start getting scars around the area and a bit of a healing process, and then we can start planning things accordingly. And I'm pretty certain that if you send somebody off with a brace who was not that stable and they have a little subluxation, you don't pick it up immediately, and then you start getting the damages happening. So I think it's much safer and easier to just put an X-fix on for a few weeks, let everything settle down. And also, I think if you're constantly with a brace, you presumably try and give them a little bit of motion, as Dr. Tapasvi was mentioning. If you tend to leave them into a 30-degree flexion, they tend to move, and that doesn't let the soft tissues heal as quickly as you just put an X-fix on. So I got a very low threshold, particularly in acute cases of an X-fix on.
Okay, thank you very much, Dr. Sachin and Dr. Rajarshi. And a couple of points and queries specifically in relation to some of the slides that Dr. Tapasvi shared. I think that's a very important point. One of the images you showed an open anterior cruciate and posterior cruciate ligament reconstruction along with MCL repair and augmentation. I think for the beginners, it is very much to be stressed that it should not go ahead with an arthroscopic procedure in a patient with a multi-ligament knee injury. It is quite possible that, someone could venture an arthroscopy in the presence of large soft tissue injury. I think it is very much important not to shy away from doing open surgery. And arthroscopy is not essential for all patients. Is that right, Dr. Sachin?
Yeah, I mean, the patient whom I selected for an open repair because there were avulsions of the femur. So all that I had to do is just to do a reattachment. And the best thing that I had was a nature-made arthrotomy, which was the MCL injury in which you have a large capsular tear. So that's what I utilized there. That's one. If you are going to do, say, an open repair, like the third case which I showed, where I did a primary MCL repair with augmentation as stage 1, and then went ahead for a delayed ACL PCL. In those patients, I do a very quick arthroscopy because it helps me look at the lateral compartment. I can repair any lateral meniscus tears. I can repair any MCL medial meniscus tears, which I will not get a chance if I go back after 2, 3, 4 months. Then I find that that I've lost the chance of repairing the meniscus. So whenever you see that there's a repairable meniscus tear that you can pick up on an MRI scan, and I will do an arthroscopy, which is a very quick, not doing long procedures, a quick 15-20 minute job, no more than that. Gravity assisted fluid, no pump, that's for sure. And then you will then proceed to your open procedure. Many a times, if I'm worried that I'm going to take longer to do a large meniscus repair, I abandon the arthroscopy. I make my open incision so that now I have a conduit for the fluid to flow out, and then I start the arthroscopy again so that I don't land up with an iatrogenic compartment syndrome because of fluid extravasation. So yes, I would do an arthroscopy in certain situations, but it's not mandatory that you should do it unless and until you have got a meniscus tear that you want to repair, or you can use it as a quick diagnostic check. You can just shave off, an ACL stump that is coming in way, and you can then proceed for your further surgical plan.
Just to add to that, I think Dr. Tapasvi mentioned, if you can do a quick arthroscopy, there are certain areas which are actually better visualized arthroscopically in the knee. Even if you're doing an open procedure, you're not going to flay the knee completely open. So there are certain corners that you actually are better off seeing with an arthroscopy, and absolutely the key is no pressure and gravity assisted fluid. Otherwise, you're just going to get too much extravasation.
Thank you very much for those very valuable points. And I do agree that certain corners are better visualized with arthroscopy, and but those very important precautions have to be taken. Dr. Sachin, in one of your patients, you mentioned that you used the split quadriceps graft in order to maintain the extensor mechanism. Can you please explain what is the split quadriceps graft?
So I think when you harvest a quad tendon, you can take it either as a full thickness or a partial thickness. So that is what I meant by a split quad thickness graft. So I've harvested only the superficial layer of the quad tendon, left the deep layer intact. And again, with the quad tendon, you can harvest it either with or without a bone plug. For Indian patients, you will usually require a bone plug because the average length of the quad tendon in Indian patients is about 55 millimeters, which is way too less if you want to do an ACL or a PCL reconstruction. So that's what I meant by not harvesting a full thickness, but a split thickness quad tendon graft.
Is this the way how you do it regularly? Are you happy with the thickness of the graft that you get?
Oh yes, definitely, for sure, because I get a thickness of at least about 7 to 8 millimeters. The quad tendon graft that you will get is rectangular, and very frequently, if you have about a 10 millimeter broad, a very wide graft with about a 7 to 8 millimeter thickness, as a split, you preserve the deep fibers of the rectus. Then you don't really violate the extensor mechanism, especially in multi-legs. In primary situations, there's no problem, but in multi-legs, if you're using the ipsilateral quad, you don't want to compromise on the rehab because you're already doing such a big job anyways. And then you can either drill a rectangular tendon, a rectangular tunnel, if you have the tools to prepare a rectangular tendon, or you can just fold it over, tubularize the graft, and then that very elegantly becomes an 80 millimeter diameter graft for sure.
Okay, thank you very much, Dr. Srinivas.
Thank you very much. Thanks for the talks, Pavan and Dr. Tapasvi. I have a few questions. One is between CT angio and MR angiogram, which one do you prefer?
So CT angio is the best, better still is the DSA, but I think it all depends upon what you're taking the patient in for. If there are no bony injuries and the patient is not going in for a CT, I'll just do an MR angiogram. If the patient is going to have a CT, then I'll prefer a CT angiogram.
And if you have an open injury with two scenarios, one with ligaments can be repaired, the other one with ligaments not repairable, how would you manage with an open injury?
So I think here there are two things. If we go by the principles, the first thing that needs to be the first thing that you need to do is to stabilize the knee with an X-fix. The second thing is that treat the vessel. Third is that if there's a concomitant nerve injury, repair the nerve, and then we come to the ligaments. In the ligaments, the structure that I want to repair first is the patellar tendon. So in an open injury, there's a high chance of a patellar tendon injury. So that's one thing that I really want to get behind and repair. The other things, if there are avulsions, I'm happy to use a couple of suture anchors and put them back, because I don't want to end up doing too much, since the soft tissue cover has to be sorted out early and quickly. So that will be my algorithm, that stabilize the knee, vascular repair, patellar tendon. If there are any bony avulsions or if there are any ligament avulsions, quickly fix them and then hand them over to your plastic surgeon colleague, because he needs to have a thorough debrima done there, and then he needs to start planning for a skin cover straight away as soon as the wound is ready to take that skin cover.
So I would add to that as well. I think your plastic surgeons are probably much more amenable and friendly than mine. I actually have to let my plastic surgeons decide what they will allow me to do, because we know that the essential thing is the whole soft tissue thing, and very often they will just not let me do anything other than just put an X-fix on and just wash out. So I'm very much dictated by what the plastic surgeons actually feel is the best for their soft tissues first, I have to say.
So when you do a staged procedure, what is the usual interval between the two stages?
So I think it's very variable between, it depends upon how compliant the patient is. Those who are more compliant, who go at it, you can get them back for the second stage in as early as 6 to 8 weeks. Anywhere it is between 2 to 3 months is that when the knee is ready to have the second procedure. You need to have good muscle control, at least 80% of muscle power compared to the contralateral side, and at least 80% of range of movement as compared to the contralateral side. If they can't achieve the range before the second stage, then I don't mind putting them through a manipulation under anesthesia or an arthroscopic release, depending upon how I feel the need to be. And then I would then delay the second stage to a third stage by another 3 to 4 weeks till I achieve these goals.
Raj, your
so I would not wait for more than 3 months is usually my goal. And actually, if I find somebody is suffering with stiffness, I just go in probably slightly earlier and do the either arthroscopic release or MUA, whatever is required, and do a part of the second procedure as well at the same time, just to prevent them from having another anesthesia and surgery, and get them back on the rehab machine quickly.
And can you give us guidelines on placing the external fixator for an acute injury in terms of placement of the pins on the femoral side and on the tibial side?
Sure. I mean, assuming that this is a closed injury, obviously that dictates some of the placements. The idea is to bridge the knee. Now there's always this common perception I hear, particularly from the trainees, we must not put the pins through the quadriceps because it causes quadriceps tethering. And I always ask them, well, actually, if you're going to bridge a knee, how does it matter what is tethering? You're actually not going to move the knee. So you want to place it so that the knee is actually reduced and stable in fixation. So I generally tend to go sort of probably anterolateral on the femur, as far away from the zone of injury as possible. There's a few things to think of. If you're going to come back and operate, and open up the knee. You don't want to mess around the pinholes. So try and avoid getting into the zone of injury and the zone of subsequent surgery. Be aware of the fact that if you go too far away, you might not get the stability that you want. So there's a balance, but generally tend to be on the superlateral area, on the femur, and on the tibia. I go on the medial crest. Again, just staying away from the zone of injury and potentially from your subsequent zone of surgery. And then in the middle, in the bars, you can use whatever number of bars connecting bars or rods you need to stabilize the fixation.
Okay, so to avoid the future tunnels, would that be, say, 10, 15 centimeters?
But that was the point, is, you think of your future surgery, you don't know what surgery you're looking to do, but yes, stay away from anything that brings those pins near your skin incision, bony tunnels, all of that. So yeah, I mean, I could give you measurements, say 12.5, but it really doesn't mean anything. It's all in the operating theater. And of course, you've got image intensifier, fluoroscopy anyway, so you should be able to see where the pins are going in relation to subsequent tunnels that need to be done.
And in the presence of extensive bone marrow edema, what is your view on using interference screws for fixing ligaments?
So if there is extreme bone marrow edema, then either you're talking of an acute fixation, and often the acute fixations are repairable, as Dr. Tapasvi mentioned. I generally tend to always use interference screws on the tibial side, endo button on the femoral side if I'm reconstructing, or direct suture anchor repairs on the femoral side if I'm repairing. And I tend to prefer metal screws. I don't think the bone marrow really matters in terms of the metal screws. The bioabsorbable screws I have issues with because they're never absorbed. So if you subsequently have to go and take them out, you can't take them out because they're kind of half disintegrated. So I much prefer putting metal screws that I can take out later on if need be. I don't know what Dr. Tapasvi's preferences are.
Yeah, I think I would agree with you. A couple of important things is that if I'm doing a PCL, I always back up the tibial fixation. So I do double fixation for the tibia. That's pretty important because it's a very strong ligament with very high forces on the same. And I think if you're looking at multi-ligament knee injuries, then probably somewhere you would end up using one fixation post, and then you can piggyback a couple of other ligaments that you've reconstructed on that fixation post as well, which makes it pretty useful to do a double fixation.
I think there are a couple of questions from viewers. One is from Hari Krishna, Dr. Hari Krishna. While doing collateral and cruciate, if tunnel convergence happens, how to get away?
Wow. So I think, Dr. Hari, I think that's a very important question. You have tunnel coalition on the lateral side when you're doing a combined ACL PLC. You have tunnel coalition on the medial femoral side when doing a combined MCL PCL. And again, you have tunnel coalition in the tibia if you're doing a combined ACL PCL with a medial or a lateral meniscus root, or sometimes you may get coalition if you're doing an MCL reconstruction with the with a double tunnel or a double graft, where you have a POL tunnel on the tibia that can coalesce with your PCL tunnel. So I'll just discuss all three of them one by one very quickly. So for the PLC, the popliteus tendon, you have to direct it proximal and anterior 25 degrees. You should drill your ACL tunnel outside in so that you can avoid coalition there. So the usual coalition that happens is with the popliteus tunnel and the ACL tunnel. On the PCL MCL on the medial femoral condyle, you first drill your MCL tunnels, you angle them proximally by about 20 degrees. That takes care. And you drill your PCL tunnel, you do a single bundle PCL because you can't have four tunnels in the medial femoral condyle, and you drill it outside in, avoiding the two tunnels of the MCL. As regards on the tibial side, you have coalition between the ACL tibial tunnel and the lateral meniscus root. For that, most often than not, you will drill two separate tunnels, but they will coalesce midway through, but you will fix them separately, which is what is really important. Second is with the PCL POL, you need to take care that you don't drill your POL tunnel more than 20 millimeters, because then it will coalesce with the PCL tunnel. So if it coalesces, once you pass your scope, you can see if the tunnel has coalesced. You pass your POL graft, fix it, and then you pass your PCL graft, which will, allow you to tension both of them. And that's probably 10-minute talk answered in less than a minute for you.
And I would also add to that use your fluoroscopy generously, because
Absolutely.
that should allow you to plan using guide wires and things where your tunnels would be. And if you're doing a multi-ligament, I think double bundles for me are completely fine, because you have too many tunnel coalitions.
I think use of a metal implant also help in identifying the previous tunnel in order to plan the subsequent tunnel.
Yeah.
Yeah.
One more question was on priorities of autograft in more than one ligament injury. Assume allograft is not available. Do you use allografts or synthetics, Raj?
So I, as you know, allografts, I'm lucky allografts are available in the UK. And I tend to have actually moved more towards using the Lars ligament now, particularly for the extra-articular parts. I tend to use the autograft for ACL. I tend to use an allograft for the PCL just because it gives me a longer length. And I tend to use the Lars for the MCL and the posterolateral corners. However, I have to say the PCL jig for Lars is really nice. It clicks together, so that killer curve passing it through with a wire is actually very simple, because you can just push a wire through from the front of the tibia and it comes out to you on the femoral side. So I have started using a few PCL Lars. The problem with Lars is it has no give. It's a very stiff ligament, and because it's artificial, so you've got to be very careful, because I have seen the Lars ligaments being used which tend to over constrain. In ligament reconstructions, we hardly ever talk of over constraint because ligaments always stretch out. But with these Lars ligaments, they're quite solid. So if you are expecting, oh, it'll loosen up in a bit, it doesn't. So you just have to be quite careful, particularly when you're doing the ACL, PCL, and you have slight subluxation chances. So that's my thought on Lars, but I tend to use Lars for the extra-articular allograft for the PCL for length and autograft for the ACL if I can get. If I can't get, then I'll use an allograft for the ACL as well.
Dr. Tapasvi, your views, please.
So I think we greatly limited with the source of allograft. I do tend to source allograft from MTF if the patient can afford it. But otherwise, my choice for a multi-ligament reconstruction nowadays is 3-strand peroneus longus for the PCL. I tend to use the ipsilateral hamstrings for the MCL. I go to the quad tendon or the BTB for the ACL. So that's what I tend to keep using. If I have a 4-ligament reconstruction that I need to do, then the quad tendon goes to the PCL, the BTB goes to the ACL. I use the peroneus longus with for doing anatomic Laprade type of technique. We wrote it up in the arthroscopy journal last year, where you can use a single strand of the peroneus longus and do a complete Laprade reconstruct type of reconstruction. And I'll use the ipsilateral hamstrings for the MCL. So these are my 4 graft choices, and I prefer to do everything from the same limb and not sacrifice the other limb for graft sources as much as possible.
I agree with that, and I think that's one of the reasons I use allografts. Is I don't want to touch the other leg. At least let him have one solid normal leg.
Just one more. I think this must be the last question from the viewers. If there is a associated full thickness cartilage loss, when to do mosaicplasty or an ACA?
So I think if it's an osteochondral lesion and there's at least about 5 millimeters of subchondral bone, then I think I would fix it primarily, because that becomes an osteochondral fragment that you can repair and fix at your stage 1, and that becomes an indication to do surgery early. If it's just macerated cartilage, there's just chondral loss without a chondral fragment, then that comes to stage 2. And when you're doing your stage 2 surgery, then I would do cartilage. So in order of preference, bone alignment is first, ligaments are second, meniscus is third, cartilage is fourth. So that's how you're going to prioritize it. And of course, you're not going to do 4 different surgeries, but you want to optimize your workflow, which is going to be really dependent upon various factors. What sort of resources do you have? What's your expertise? And there are such a lot of multitude of factors here that are involved, but usually I would want to do it as a part of my second stage when I'm doing a reconstruction, if there is chondral loss and not a chondral fragment. A chondral or an osteochondral fragment behaves a lot differently than chondral loss.
And I'd like to add that, I mean, if I'm doing a reconstruction where I'm going to brace a patient and I see a chondral loss, I actually tend to do microfracture at the same time, because they're going to be immobilized and non-weight-bearing for a few weeks. There's no harm. It might not work, but at least you've got it in front of you. Sticking a couple of holes in there might not cause any damage. But I agree, if there's a osteochondral fragment, I tend to use the chondral plugs, the arthrex ones, which are quite useful at sticking those back into place. And yeah, if it's a major, again, we talk of these things a lot theoretically, but if you're looking at multi-ligament knees and major injuries, there's very rare cases where you see these nice circumscribed chondral losses and little osteochondral fragments. It just doesn't happen. They're either pretty badly damaged or they've been spared.
Okay, if you allow me, I would like to ask 2 quick questions.
Sure.
Yeah, Dr. Sachin and also Dr. Rajarshi, I want to give you 2 scenarios. What is your opinion about harvesting the hamstring graft for a patient with grade 2 MCL injury and for another patient with grade 3 MCL injury? Hamstring graft, would you go ahead with harvesting the hamstring graft for a ACL reconstruction or a PCL reconstruction?
Sorry, can you just ask that question again? Grade 2 MCL injury.
You have a patient with a grade 2 MCL along with a complete ACL injury, and another patient with grade 3 MCL and a complete ACL injury. What is your opinion? What is the choice of your graft? Will you go ahead with harvesting the hamstring graft?
Yeah, so for me, I'd hamstring harvest both times for the ACL. If it's a grade 3 injury for the MCL, I use a LAS to reconstruct. I don't tend to use the hamstring because I prefer it for the ACL. If it's a grade 2 MCL injury, I probably would not be doing anything. I'd just brace the patient and expect them to heal up in any case.
Yeah, okay. Yeah, Dr. Sachin, please.
So slightly different point of view here. Grade 3 ACL, MCL, ipsilateral hamstrings for doing an MCL reconstruction, ipsilateral BTB for doing the ACL reconstruction, grade 2 MCL with ACL, ipsilateral BTB or quad tendon for the ACL, hamstrings for augmenting the MCL.
Okay. What is, Dr. Sachin, because you said you wanted to augment the MCL even for a grade 2 injury, what is your opinion about going with ACL reconstruction alone and going slow with the rehabilitation? How do you think, is that okay? That's not at all okay, because these patients are never happy. If you have grade 2 laxity, not grade 1, grade 2 laxity, where the opening is up to 4 millimeters, then they will not be happy. Though they will not have functional disability, but they cannot return to sport. Whenever they try and run, they will experience that slight gapping or giving way, and they will develop over a period of time some valgus instability. So for them, if you, the other corollary to this is that it's not uncommon where people come and ask that, I had planned for an ACL, MCL, I did the ACL and now the MCL is stable. So I'm not doing that. That's not correct. So you evaluate your instability before your surgical procedure,
when you do your EUA, and all of that has to be corrected during your surgery. You can't say, oh, I've done ACL, I've done PCL, now the PLC is looking fine, I won't do it. No, it is going to come up afterwards. So whatever you see pre is whatever you need to do intra, so that you have a good post.
So I just qualify a bit of the answer I mentioned, because I kind of mentioned to you about, and I agree with Dr. Sachin, that you can't leave a lax MCL on table. But if I have an MCL grade 2 and an ACL complete, I would brace and I would wait to see if the MCL heals before I actually commit the patient to surgery. So that's why I was saying that I wouldn't do a grade 2 MCL. If you're braced and the patient hasn't healed, then you're committed to surgery for the MCL. It's not, it's clearly not then a grade 2 staying as a grade 2. It's become non-functional.
Okay, thank you very much. And the last question is, do you think adding up an augment in whatever reconstruction that you're doing is going to, hasten the rehabilitation? And do you use it? Do you use an augmentation device along with a MCL reconstruction or ACL reconstruction or PCL reconstruction? And do you think that can help with early rehabilitation or not?
So I obviously use a Lars for my MCL, and you can go straight on with it because it's just as strong as it will be from the day you put it in. So I don't do any other augments. For the ACL, I just do my standard, and I don't see any reason to hold back the rehabilitation.
So Dr. Sachin, please. Yeah.
If there is a mid-substance tear, and we have repaired a mid-substance tear on the medial side, always augment. If you have access to Lars or any such type of artificial ligaments, you can use it. If not, then I just harvest the CVT, leave it attached distally, secure the distal fixation with a suture anchor, bring it down up to the MCL, and then bring it down to the POL, like a Danish type of reconstruction. If you do a primary mid-substance repair on the posterolateral side, always augment with the help of autograft, because the results of repair alone are far inferior than the results of repair with augmentation. So that's for both your collaterals. As regards the ACL and the PCL, I would not augment with, say, a fiber tape, which is quite popular with an internal brace technique. I will not do that, because the graft, autograft, and the internal brace have different modulus of elasticity. They have different stress tensile patterns, and if you don't use that internal brace properly, where you tension it separately from the graft, then your graft will not have good biological integration, because the tape essentially stress shields the entire graft. So I think you should not mix concepts here. And that's again one huge misconception, where people say that I didn't get adequate diameter, so I'm going to add tape and make it thick. I think that's wrong. I don't think it works at all. Because the moment you start putting tape to increase the bulk of your graft, the tape is going to take all the load. There's going to be stress shielding of your autograft, and that's not going to integrate or undergo biological integration at all. So that's very important for you to give back as a take-home message.
Can I just ask, because I don't know for sure, do you guys have access to Lars ligament in India? Is it quite expensive?
No, we don't have Lars. We have that other British company. What's that name? Arthro. Which is that other British company?
Arthrex.
No. Arthro ligaments or something. They're like Lars. It's another British company. I keep forgetting the name. They had, and they have those tapes for the AC joint and all of that. I just keep forgetting their name. They have come in, but not to a great extent actually.
Right.
Okay. I think that was a wonderful session. There are very complex case scenarios, a lot of discussion about dislocation scenarios and also multi-ligament knee injury scenarios. It was a wonderful session. Thank you very much, Dr. Pavan, Dr. Sachin, for taking your time in spite of your busy schedule, and Dr. Rajarshi also for taking your time to share your knowledge with us. I thank you very much. It's a great privilege to host you all. I hope to see you all some other time in future. And
thank you very much. It's been a pleasure and a privilege to listen to the talks.
Thank you very much.
Thank you very much, and thank you, Dr. Ashok.
Yeah, thank you.